I've been a pediatrician for kind of now over 20 years, feels longer. Um, and I've been at GWH for the last, I think, about 10 years, I think now. What I wanted to do today really was give you all a whistle-stop tour of ADHD. Now, I've said whistle-stop. I actually don't know if it's whistle-stop because I've not timed myself doing this talk. I haven't had a chance. So I have no idea how quick or how slow this is going to go. I hope to keep to time. We've got about, I think, 40 minutes for the talk and then time for questions afterwards. So, which I'm happy to do. I'm hoping it does keep to that order, though it might vary a little bit either way, if that's okay. I think questions are going to come at the end. I think it is going to be recorded as well for people that can't make it, and then Sharon's got that, and I think comms will have it on a YouTube thing, I suspect. Yeah, I think Sharon is recording that. Okay, so right, let's get into it, if that's okay. What I'm going to do really is talk about kind of what ADHD is. So we're going to talk about definitions and criteria because that's where we really need to start. We're going to talk about why it is. So kind of where does it come from? Why do people get ADHD? A bit of the pathology. I'm going to try and not go into too many details. As a doctor, I am very prone to jargon, and I don't realize I'm doing it. So apologies if I say stuff that isn't clear. We can clarify stuff in the questions if need be. And then we'll talk about kind of how is it? So how do we diagnose it? How do we manage it? I'm going to talk more generally about that, but also focus on perhaps Swindon and kind of what we do, because that does vary across the country and that might come out in some of the questions. And remember, kind of I'm pediatrics, I'm not adult, so that's a whole different world, but I'm happy to kind of discuss that because I think it's an important area. And I'm going to talk about that in a little bit in the challenges at the end, and then we'll do the questions if that's okay. So I didn't start my timer. If everyone stays on mute, that would be good if you can. Right, so what is ADHD? So our definition of ADHD comes from the Diagnostic and Statistical Manual of Mental Disorders. So it's version 5 of that manual. It gets republished every about 10 years. It's American based, but it's one that's used in the UK quite regularly, and it is pretty robust actually. And what we define it as is a persistent, and I've bolded the important words here, persistent pattern of inattention and or hyperactivity or impulsivity that interferes with functioning or development. Those words I'm going to break down a little bit. Persistent is a really important one though. So this isn't about you having had a really bad day or having heard something really horrible and thinking about it, being distracted. And that doesn't mean you've got ADHD, because persistent means at least 6 months. So it's got to be persistent. What we talk about when we talk about the characterization of it, we talk about inattention and hyperactivity and impulsivity. So inattention is having 6 or more symptoms that are persistent for more than 6 months that negatively impact social and academic or occupational activities. So it's got to be kind of these two big areas of your life that this inattention is impacting. The other side of it, and this is the and or bit, is hyperactivity and impulsivity. And this is again 6 or more symptoms that are persisting for more than 6 months that are negatively impacting social and academic occupational activities. So there's a few important bits there. What I want to kind of do first is break down the word inattention, because one thing that has really changed from the DSM-4, which was I think before 2013, and then into DSM-5 in 2013, is that specifying of what we mean by inattention and hyperactivity and impulsivity. So inattention is failing to give close attention to details, making lots of mistakes in schoolwork or at work or during other activities. It's also difficulty sustaining attention, getting really easily distracted by things and by kind of phones, by other things when you're meant to be reading a book, for example. It's when you don't, someone who, when you're talking to them, you just doesn't seem to be listening. They just don't seem to listen to you directly. Mind seems to be elsewhere, even in the absence of obvious distraction. So, they could be in a quiet room and you're talking to them and they just seem to be kind of away with the fairies. It's disorganization. Having kind of tasks and activities that you're meant to be doing, but you just really struggle to organize those. That could be chores, it could be schoolwork, it could be duties in the workplace. It's this feeling of when you have a mental task that's quite difficult, just not wanting to do it. So procrastination is kind of that's often termed up, but it's a bit more than that. It's a real distress thinking about something that you need to do and really not wanting to do it. Um, it's not following instructions. So everyone's going in one direction. You're meant to follow the line, and actually, you're actually wandering off across the road or something like that, or you're distracted. You're staring at something else while everyone else is doing what they're meant to be doing. Losing that attention on things that you need to be doing. Um, and then it's also forgetfulness in daily activities. Again, it's kind of, in younger people, it's running errands, doing chores, getting ready in the morning is the classic one that I often kind of talk to parents about. And, you send them to get their clothes on and actually, you know, they're kind of staring at something, or they're kind of counting paper clips for no apparent reason. So it's that forgetfulness in activities. um, so that's kind of the inattention side of it. Um, Next, we come to hyperactivity. So again, there are very specific things that we kind of focus on with hyperactivity. It's often fidgeting, often kind of fidgeting with moving their hands, squirming in their seat. They're meant to be at the dinner table and they keep on moving around and doing other things, leaving their seat in certain situations when they're expected to stay still. So that's often in places like school, where they're kind of not quite this bad but can be kind of on their chair at the worst and wandering around the room. It's being often running around or climbing in situations where it's inappropriate. So that can be kind of crossing roads. I think someone's got their mic on there. I can hear a bit of background, but it's crossing roads is the classic one. But it can be other situations where they're meant to be kind of visiting a zoo or a museum and they're climbing on all the exhibits and just can't seem to help themselves. Restaurants is another classic one where they're really struggling to stay still or be still in a restaurant. It's when they make loads of noise when they're meant to be doing a quiet leisure activity. So they kind of are meant to be kind of quietly doing something, but or they're gaming and they just make loads of noise. There's loads of outbursts constantly, which can be a bit of a headache sometimes. Um, then it's kind of not being able to be in a queue, not being able to wait their turn, always wanting to push forward, and really struggling with that element of it. Um, and that can be often in games as well, not being able to take turns in games, really struggling with kind of when it's their turn to play tig, they want to be the one playing tig, they want to be the one kind of at the front of the queue doing what they're meant to be doing. And then the other classic one is interrupting, butting into conversations or games, kind of starting using other people's things without asking or receiving position, or intruding on conversations. My wife tells me I do that a lot. I mean, I do. I find myself interrupting, in the middle of conversations, which can be really, really annoying. But that doesn't mean I've got ADHD. Now, half of you, when I've gone through those conditions, those features, I think half of you, or even all of you, will think, God, I do that. I do that a lot. Or, someone told me I do that. Or I know someone that really does that a lot. Do they have ADHD? And that's where it's really, really important to think about. There are lots of caveats to this because what we were describing with ADHD, I do not term it as a disease. It's in this diagnostic manual of mental disorders, but it is not really a disease. It is, and we'll kind of come on to this a little bit later on, actually. It's a way of describing some people that struggle more with these very normal elements of human existence. So in terms of diagnosing, there are lots of caveats that we need to think about. So just going back, you need six of these, each of these, to be able to diagnose ADHD. They need to be persistent over a period of time, and they need to be in two or more domains. So um, they also need to be inconsistent with the developmental level, and I'm going to come on to that in the next slide. I'll come on to it, but kind of, every 3-year-old you meet has ADHD. They struggle with all of that stuff, but that doesn't mean they actually have ADHD. We can diagnose them with ADHD. It can't be due to oppositional behavior, hostility, or lack of understanding. And this is one that is often quite tricky to tease apart. Some kids sometimes are not happy for all sorts of reasons, and they can present with lots of these sorts of difficulties, kind of seeking danger, being fidgety, running around, not paying attention, struggling with homework, not wanting to start homework. The other big one that I often have to deal with is this a learning problem? Is this a child that actually cognitively doesn't really understand what the teacher's saying, and that's why they're not paying attention? So that again, again is not ADHD. So you've got to tease that apart. It must have been present before the age of 12. I think this is a real challenge for the adults because some of the adults, when you're talking to a 40 or 50-year-old about whether they've got ADHD, they don't quite remember what has happened before the age of 12. It can be quite muddled. So that's why I think for us as pediatricians, it's a little bit easier in some ways to diagnose. But it must have been present before the age of 12. Where I see this sometimes is when I see kids who present to me and parents say actually this is something that they were 14 and kind of they're really struggling to concentrate, and actually I find it's normally associated with some trauma that's happened, something really difficult that's happened in the family or in that child's life that's resulted in them really struggling from a mental health point of view, and is presenting with what looks like might be ADHD but actually really isn't, because when you look at the developmental history, um, uh, when you look at the developmental history, none of those signs were present before that time. And like I said, it's got to be present in two or more settings. And again, this is something that we in the past have often fallen down on, and I think families and parents struggle with this element where schools don't seem to recognize an issue, but they see lots of issues at home. That can often be a real challenge, actually, because even getting into the process of being referred requires that recognition of difficulty in two or more settings. And I suspect a lot of the questions will be about this, as well as kind of separating trauma from and learning from ADHD, but we can kind of expand on that a little bit. Um, and again, this is the other one, evidence of reduced functioning, and I'm going to come on to this a little bit, I think, in the next slide, because I think that definition of functioning is really important. And symptoms can't be better explained by another disorder. So this is where I have to deal with a lot with comorbidities, and the big other disorder that I often deal with is autism, is the other thing to think about, and whether that explains it, or kind of there are other kind of disorders that can kind of explain it as well. I think in the adult world there are kind of personality disorders that overlap a little bit with ADHD, but I'm not an adult psychiatrist, so I can't comment further on that. So that's kind of those caveats which are really important. So coming back to what we've talked about this idea of persistence, we've talked about this idea of inattention and hyperactivity, impulsivity, and now we come on to things like functioning and development, which I want to talk a little bit more about. So by functioning, what do we mean by that? We mean the ability to carry out specific tasks and participate in order to fulfill a role in society. Okay, so The ability to carry out specific tasks for a child will really vary depending on where they are. So if they're at school, the tasks they're being asked to complete are going to be a bit different from the tasks they're being asked to complete at school, at home, or on holiday at home, or at school on a school trip, or at school in maths versus English. There's a lot of variation in terms of what they're being asked to do. And this idea of participation in order to fulfill a role in society, society has a lot to say in that ability to function. So, kind of an example, I'm probably jumping ahead into the management, but an example I often give in this is when I had a kid who was at school here in England and was on quite a high dose of medication. And the family moved to France for a couple of years. And actually, when they moved to France, the dose of medication needed to be dropped. It didn't need to disappear, but it dropped quite a lot. And it was because he only spent half the day at school and the rest of the day he was out in the fields doing whatever. And actually, he didn't really need that much medication to manage because actually society's expectation of him was not the same. And if you look back through history, and I'm going to talk about the history of ADHD a little bit, a lot of these kids left school by the time they were 12 and didn't really need to stay. Now we expect these kids to stay in school, sit in a chair in a room with 30 other kids in not a great work environment. I mean, I wouldn't want to go back to school, I'll be honest with you. And they're expected to concentrate and focus and manage up to the age of 18. And for some, it's just a lot harder. It's not impossible. It's all very doable, but it is a lot harder. And I think that is something that really does need to be taken into account when thinking about this specific condition. So that's about functioning. And then it's about behavior. Behavior is the outward expression of internal cognitive, emotional, social, and cultural factors when interacting with the world around you. In ADHD, we really rely on behavior to flag these cases and also tell us how bad is this condition. That relies on not just a physical or pathological problem, it also relies on a whole bunch of other stuff. It relies on this kind of cognitive, emotional state of the child. What else is going on in this child's life that's impacting their emotional regulation? It isn't often just ADHD, it's also parenting style, it's also what is going on with the parents, it's also kind of what is there any bullying at school, it's kind of what that child's own emotional threshold is, and that threshold can vary from child to child for all sorts of reasons. What are the cultural factors? What else is kind of what does that child's culture say about behavior and what behavior should look like in particular settings? What does that child's culture say about education and the importance of education in particular settings? So there's all sorts of stuff that influences behavior, and that then influences our ability to recognize issues. And it's often, you often can't separate one from the other, or certainly we don't have a good tools to separate one from the other with this sort of stuff. So that's functioning and behavior. And then we come on to development. And I mentioned these aren't my kids, thank God. But this kid, I think is probably about 3.5, I reckon. This kid is probably about two and a bit. I mean, if you left a bot of white paint in your lounge with kids, this is what you're going to see, likely. That again is not ADHD. This is developmentally. I mean, I'm going to say normal. I'd be furious, but it's not unexpected for this to happen. So you wouldn't label this as ADHD. If these kids were 8 and 10, that is a little bit of a different story. There is something going on there. Whether it's ADHD or not, I don't know from this one, but it's certainly, something a little bit impulsive. But again, we come to kind of development and kind of I'm going to talk about this a little bit when we come to the pathology, but development of children, what happens normally, and I mean this is the press I give a lot of families, is in the first 2 years of life of development your brain changes to wire up all of your motor bits. So your brain starts wiring up your neck so you can move your neck around, so you learn how to look around within the first kind of few months. Then it learns how to wire up your trunk and your arms so you can move your arms and reach out for things and sit up. by about 6 months, and then by the time you're 12 months, you're learning how to walk around and crawl. You've crawled and you're walking around by 12 months ish, and you've wired that up. And then you learn a bit more fine motor control. And by about 2 years, you're wired up. Then from about 2 years up to about 7 years, the surface of your brain starts building networks. So each nerve cell, and there are about 100 billion in your brain, starts connecting to about 1,000 other nerve cells. So you've got 100 billion times 1,000. That's more stars than there are in the universe. That's the number of connections that you've got in your brain that need to build, and they form really complex networks. Those networks talk to all the other bits of the brain, and the reason they talk is to develop these abilities to process and manage the world around you. And part of that is working memory, your ability, your short-term memory, your ability to understand what you've just done and hold that when you do the next thing. Your cognitive flexibility, your ability to move from one task. So you're doing a talk, someone knocks on the door, you talk to them, and then you come back to your talk. That sort of stuff. So that's your cognitive flexibility. Your inhibitory control, your ability to stop yourself doing the things that you shouldn't be doing. So the ability to stop yourself from getting a pot of paint and shoving it all over the lounge, that's inhibitory. That develops over those kind of 5 years and then grows. Planning and organizing, your ability to organize yourself, to get your school books, to put your coat on when you need to get your shoes and put them on when you need to. Your emotional regulation, your ability, that surface of your brain, that rational bit of your brain, ability to suppress your fight and flight response, that starts then. And your initiation of tasks, your initiation of things, and then problem solving, your ability to take an abstract problem and solve it, and a word problem and think about it and solve it. So all of those things are part of your executive functioning, and they work for things in school, they work for things at home, they work for all sorts of activities in daily life. And that's what needs to develop. And that's what I mean by development. And that's why these kids, I'm not surprised they do this, because they haven't developed that inhibitory control. They haven't developed that emotional regulation and that problem solving. So that's why they do this stuff. And that's normal. But when they're 8, I would have expected them to develop some of this stuff. So that's what I mean by development. So that's the kind of what it is. Okay, so we're 20 minutes in, so we're not bad for time. So that's what it is. So we'll park that. Okay. Um, so now I can't remember what I said. I think it said how um, uh, why it is. Um, I think I talk about, or how it, yeah, why it is what we talk about now. So why it is kind of, you know first of all, kind of the prevalence of it. Where is it all? Um, I've forgotten to, I knew I'd forgotten. I've forgotten to add our local Swindon. I'll try and remember our local Swindon stuff. So the prevalence, so this is global data now. Prevalence ranges from 2 to 7% of all school um, children, which is a mean of about 5%. That, in the nature of when you talk about disease, is very common, or fairly common, certainly. That is approaching kind of asthma and diabetes levels to a certain extent. It's up there in terms of how common it is. It does vary between populations, and I think there is significant variation in that percentage, but it's a lot. Um, the rates have doubled between 2003 and 2018, and that's for a lot of reasons. I think every time I use this statistic, the common reason thing that people come back and say, "Oh, it must be phone use." There is not a that's not an unreasonable thing to say, and I think there's a lot of questions technology companies have to answer for, in terms of designing algorithms that really provide a dopamine response. But gambling has been around for centuries, if not millennia, and that is the same thing in terms of that dopamine response. There are many other things that encourage dopamine response. So I do not think phones are the sole cause of this at all. I think the cause of this probably likely is much better recognition, and certainly better diagnostic processes and more robust diagnostic processes, not only in the UK, but I would argue more in other countries that historically didn't recognize this. So I think it's more societal change in other countries that have resulted in this rate doubling. Um, the male to female ratio is 3 to 1. That hasn't really changed. Again, is that a biological thing or is it a kind of recognition thing? I think probably a little bit of a mix of both. A lot of recognition. In autism, interesting, and this is a bit of a divergence. In autism, that ratio changes to 1 actually. So in autism, I think it is much more recognition. I think ADHD is a little bit of a less of an issue, but I may well be wrong with that. I don't know the literature well enough to be able to say that certainly. Mostly diagnosed after 6 years of age. So again, this is about waiting. This 6 years of age is about waiting for that network to develop those executive functions to develop appropriately for us to say, you know what, this isn't about development. This is something that's persistent and pervasive and needs diagnosing. That's why we end up waiting. I do rarely diagnose before the age of 5, but it is very rare that I do that. The bit I missed was about Swindon data. I was having a quick look at our data just to see if our prevalence rates match this 2 to 7%. I think now, if we look at the rates of cases that come through for ADHD, which is about a third at the moment, it's about 25% to 30% of our referrals yearly, which is about 750 cases yearly. So we're looking at 200 to 300 cases a year, and we take that population over 12 years and we compare that, we're about 4% of all kids in Swindon have ADHD. That's better than it was in terms of that's approaching reasonably good recognition levels now of it, and that's taken a lot of work. I suspect that was a lot lower about 10 to 15 years ago. So I think we're still missing a few, but we're catching much more of them than we were. Those are very rough numbers. Please don't quote me on them. And when this goes out to YouTube, kind of, um, it's something that we would need to kind of have a bit more robust analysis of. But I think generally, I think we are picking those up. We'll talk a little bit more about Swindon because I'm sure there's lots of questions at the end. I've got a slide on that as well. So that's kind of the prevalence. I want to talk about the history because I think this is missed a lot actually, because everyone says, oh, it's a disease of modern times. You'll get these people that kind of comment on that. It is really not. So Melchior Adam Weikart in Germany published Der philosophische Arts, which was an inquiry into the nature and origin of mental derangement. No, actually, the Weikart's text wasn't that. It was Crichton's text, which was an inquiry into the nature or origin of mental derangement. Melchior Adam did a text that contained descriptions of ADHD-like behaviors in a more general philosophical treatise. Crichton's was much more specific on disease, and he actually distinguished two possibilities of abnormal inattention as oppositional poles of increased or decreased sensibility of the nerves. So we're back. The pathology that they're talking about is kind of nerves. It's soft. It's not based on a lot of evidence, but it's starting to be there. But certainly this recognition of inattention being an issue is there back 200 300 years ago. Then a really famous case is in 1844, the German physician Heinrich Hoffman kind of did these, and I took a picture from his book of children's stories. This is when the Grimm fairy tales was out as well. But this guy called Fidgety Phil or Zappel Philip, who was at the dinner table and just wouldn't stop, would always sit still, would always mess around pulling things off, and he got beaten to death this was a children's story, and you find how horrific these children's stories, but he gets beaten to death, and actually there's a really unsettling echo of this in kids with ADHD who are more prone to safeguarding issues. It's a genuine thing, and actually it's interesting that was recognized in 1844. A big thing that happened in 1902 was Sir Frederick Still did these Gulstonian lectures to the Royal College of Physicians on some abnormal psychical conditions in children, and he discussed the particular psychical conditions concerned with abnormal defect of moral control. So there's a big connection with morality and ADHD that he connects together, and he presented 20 cases that when you look back actually are really good historical descriptions of ADHD. He describes them as a defect of moral control but without general impairment of intellect. So there is this kind of differentiation between actually bright kids, but actually there's this lack of inhibition. It's interesting that morality plays a big part in his description, and in fact one of the medical societies that focuses on ADHD is called the kind of the Stills Forum, based on named after him. So it was very influential. And then kind of we come to Charles Bradley, and this is a really interesting. I mean, I use Charles Bradley as an example when talking about this. So Charles Bradley in 1937. So a lot of these kids, if behavior got really worse, would be put in institutions. I mean, that's what would happen. Pre-war certainly, and even a little bit post-war, they'd be put in institutions. They'd be taken away from families, put in institutions, and essentially experimented on. And this guy, what he did was he was performing pneumoencephalogram. So what a pneumoencephalogram is, in those days, X-ray was new. You could take an X-ray of the brain, for example, but all you saw was a skull. And what people noticed was if you injected air into the spinal column, you could then see the brain because the air would go into the fluid that circulates around the spinal column and the brain, and you'd suddenly be able to see elements of the brain. So this guy was injecting air into the brain, and shock horror, it was causing terrible headaches for these kids. So what he did was he attempted to treat the headaches by using benzodrine, which is a, a sort of version of methylphenidate. It's a stimulant essentially. And what he noticed in about 20 kids, it caused a striking improvement in their behavior. I mean, at this stage, I mean, that was unheard of. And and at that stage, I mean, these kids did have ADHD, and actually, this stimulant really improved. They allowed to focus, and they were better, as well as kind of managing the headache. Now, it wasn't taken on at that stage. It wasn't really recognized, or nothing moved on, because psychoanalytic techniques. So Freud was big at that stage, and it was thought that these kids' problems were psychoanalytic in nature. It was a problem with their perception of their mother and their father, and all of that stuff. So it wasn't pursued. And it was only kind of in the 1940s when methylphenidate was synthesized and used kind of in the war and for RAF pilots to help the concentration, that this started gaining ground, and medical intervention started gaining ground. And then kind of, this idea of minimal brain damage, this concept of minimal brain damage, these kids were lumped under that term in the 1950s, and then in 1968 this hyperkinetic reaction of childhood was recognized, and we start seeing modern ADHD being defined in the early 80s, and then more recently in DSM-4 with ADHD and its subtypes, and then in 2013 the DSM-5, which introduced the concepts of persistence and pervasiveness. I mean, they were there beforehand, but what DSM-5 did was they put a little bit more detail around what the symptoms actually are. So that's kind of an interesting timeline of ADHD. And then coming to the pathology of it, I'm not going to go into great detail. This is just these are the networks. So you can see there's surface networks and there's deep networks, and it's the connections between the two. And ADHD at its heart is a problem with the chemistry. It's a problem with the chemicals that allow these networks to function. Okay, I'm going to leave it there. My talk, I do a talk for students and for professionals. I do it a bit more on this, but I'm not going to because it'll be boring. But the other thing to talk about is this idea of, and I think this is a really vital concept. This idea of there is a real component of genetics, which we're getting much more aware of now, um, and environment and neurobiology, which is this bit, coming together and impacting deficits and producing deficits in attention, impulse control, and hyperactivity. These things are very hard to tease apart, how much each one kind of impacts. Um, and I just want to talk about some of kind of where you can kind of differentiate this reasonably well is when you look at the risk factors for ADHD. Um, but I think this model is really important to keep in mind. Um, so the risk factors for ADHD are really interesting, and I've done a bit of work on this actually, which I'll come to. So the big one is looked after children and young people, and I find this is I saw in the chat this idea of kind of how do you differentiate trauma and ADHD. Uh, you know, if you could give me an easy answer, I'd be very grateful because it is nigh on impossible sometimes to tease out the two of them, and some of it is experience, some of it is the tools we use, some of it is time and figuring it all out. So there is no easy answer to that one. But looked after in children and young people, the rates of ADHD are much higher in this population. Children and young people diagnosed with oppositional defiant disorder and conduct disorder. I think this one's a bit of a tricky one because actually oppositional defiant disorder and conduct disorder are tricky ones to diagnose. We don't officially diagnose them, although we recognize their behaviors and we know where they come from, but I'm not sure what they mean in terms of pathology actually, and whether that's the same. We absolutely do know that those who have oppositional defiant behaviors, there is often a risk of having ADHD as well. Those two do go together. I don't know whether I come onto this late. Actually, I can't remember if I come onto this, but uh, people in prison, there was a statement that actually 25% of people in prison have ADHD. That's not true, actually, because people have gone back and reanalyzed that data. It is about only 4.5% of men in prison have ADHD. So it's about the same prevalence. It's far higher than a general population. If you took the same group of men in the general population, that prevalence would be far lower. So it is higher in, but it's not a quarter. So that is not true, but it's still higher. But some of that comes from conduct disorder, which is involvement in the police as well. Um, then adults with a mental health condition. So this is kind of this is what we mean by parents with a mental health condition. Children tend to be more prone or have a higher risk of ADHD. Adults and children with a history of substance abuse, children tend to have a higher risk of ADHD. Yeah, children known to the youth justice system or adult criminal justice system. I think that's kind of collinear or alongside those people that have those children that have a conduct disorder. So I think those two go together. But those are more the environmental risks. Biological risks. This is kind of the work I've done. People born preterm. The more preterm you are, the more higher your risk of ADHD and autism actually. And kind of the piece of work I did, your risk quadrupled if you were born before 27 weeks gestation. So there's a big risk there. And I think again, it's about networks and the way that networks develop. There is an impact of being born preterm. You're in the wrong place. You're meant to be in your mum's tummy, not out in a horrible I mean, I say horrible. My SCBU colleagues will be annoyed with me, but it's not the right place. They try and make it nice, but it's not the right place for brains to develop. So I think that's kind of the impact. That's slightly different to the chemistry being impacted, and again I think this is where we get into the nuances of ADHD management. Problems with network that are persistent and problems with chemistry are a little bit different. So children, young people with mood disorders, again I think that's a bit about the chemistry that an independent chemistry that affects your ADHD. People with epilepsy, again, epilepsy is a problem with brain networks, and actually they're more prone to ADHD. people with a close family. Remember, this is where we come with the genetics of ADHD. People with other neurodevelopmental disorders like autism are more prone. And again, I think this is partly genetic, partly processing, um, partly the chemistry of the brain that's being impacted. And people with acquired brain injury, this is really difficult. I mean, I see a few of these actually. Children that have had a really traumatic brain injury that resulted in either a brain bleed and then a move to the intensive care and quite quite significant impact often afterwards are left with issues with attention and concentration, and that can look a lot like ADHD. So that's the kind of um, uh, why it is. So that's that section done. Um, Next, we come on to kind of the how is it? Oh, what do we do about it? I mean, what's our diagnostic process like? Now, we've only got kind of, 5 minutes left, so these are going to be fairly quick slides. So what we do a developmental interview, we do an examination, so a physical examination, and we observe. So kind of we often do all of that together in one session. I'll talk about what Swindon do perhaps in a moment, but kind of we do that in one session, and we're doing it all pretty much together. We then do a validated questionnaire. It's known as the Connors questionnaire. There are others, but that's the one that most people use. And we send that to home and to school. Um, we also now do something called continuous performative testing. So that's for us, it's QB testing. Other people use CPT3. So that's where we observe the child sit and do a task, a boring task, normally on a laptop. It's what we call a psychometric test. It's measuring an element of their psychological ability using a standardized test. And I've put that kind of three-sided bench because actually that's three-sided stool because we rely on those legs to give us a robust diagnosis. I often say to parents that there is no blood test for ADHD. If there was, my life would be a lot easier, but there isn't. It is about gathering evidence and gathering robust evidence. And actually, for us, I think the biggest change in the last few years is this use of the QB test in particular situations where we're struggling to really identify ADHD because sometimes it's not recognized at school. Sometimes that behavior is not obvious at school. And actually, this QB test gives us this really good measure of, okay, actually, are we missing something? What is actually going on? And it's a really useful tool. And I'm very aware that NICE are looking at the technology, and I think it is going to be recommended more formally. But again, don't quote me on that because I'm not sure whether that's been published yet. That piece of work. So we do that. If we're struggling, we ask educational psychology to help us. They're a really useful, very expert resource to help us understand ADHD and behavior, and especially executive functioning. That's where we kind of use them a lot in. We also sometimes ask CAMS if there is a problem with kind of mental health complexity or general complexity to the case that we're not sure what we're looking at, and they can sometimes help. And then we kind of conclude that can be a yes or a no. We do use subtype. I do sometimes use subtype. What we mean by subtype is this an inattentive dominant ADHD, or is this a hyperactivity impulsivity dominant ADHD, or is it a combined type? I have to say, I mean, personally, I don't often focus on the subtypes. There's often a bit of both depending on what's going on. But sometimes it is really useful to kind of focus on that. And actually, the QB test has really helped us kind of define that a bit more clearly because sometimes one is more obvious than the other. And then kind of, are there any comorbidities? Do we need to worry about other diagnoses? Is there something else going on that we need to think of that helps us explain the child? And I think this is the other thing to say about these kids. When parents come to me, this isn't about me finding a label ever. You know, I think I come onto this a bit later on, but this is about what helps us understand this child and the needs of this child. Because this, at the end of the day, me labeling kids with ADHD doesn't change who they are, doesn't kind of do anything else. But what it helps do is it helps other people, parents, the child themselves, and professionals understand, give a shorthand of understanding this aspect of this child. It never describes everything about a child, and I think that's always really important to remember. Um, I think just the Swindon service, just briefly, we kind of oh, sorry, where am I? We triage all referrals, and we require evidence of impairment and interventions over at least a 6-month period. Often that's the early help documentation. Those are triaged. All of them are triaged, and then they come through. Our referral rate is about kind of total is about hitting, like I said, about 700 a year now of cases. Um, the current wait time for us for all cases is 18 months from referral. That is for routine cases. Urgent cases, which are all under 5, so that's what we define as urgent. We will see a lot quicker. That's about 8 months at the moment. That is now going up again. We did get it down. It was at one stage, I think it was at one stage about 2.5 years was the longest. Some were a bit more than that. But we did get that down. There's a big standard deviation to this, so it does vary a lot, but generally it's about 18 months now. We've seen our referral rates tick up over the last year more significantly. So, and kind of capacity has been a bit of an issue. So this is growing up slowly. Um, from initial appointment to diagnosis, it's approximately 3 to 6 months. So once we see, we can normally diagnose in 6 months in simple cases. A lot of the cases are not simple, and actually it takes a lot longer. And this really depends on complexity and also kind of returns of questionnaires and all sorts of, and whether we need to do a QB test, that all those add delays. Generally kind of the longer ones are up to a year from initial appointment to diagnosis. Very few are longer, and normally it's longer because it's complicated and we're trying to get the right answer. And that can often be really frustrating for families because they've waited a long time, not only to see us, but also then to get an answer. We do a 60-minute clinical interview initially, and then generally it's a 30-minute follow-up, normally on the phone, and then there's 45 minutes admin time. So total time to diagnose is about kind of just over 2.5 hours-ish. We have a mix of consultants and nurses and specialty doctors. It's quite a good mix. Um, uh, um, so we're quite good. Other areas in the country aren't as lucky as us in terms of the mix we've got. We do advice, we do signposting, and we do medication. And we are starting to do a bit of psychoeducation, which I might come on to. I'm running out of time, so I'm going to briefly go over the management. Again, I'm not going to go into detail with this. Really, environmental and school changes are the big things we advise. So schools adapting to the child's needs, they know what to do. Um, you know, as in all schools, they're under pressure. Some schools are better at this than others because of the expertise that sits there. Some teachers are better than this than others. That goes for life. That's just life. But there are things that can be done that are fairly simple that can help. In terms of when you look at the literature and evidence, psychoeducation actually has really good evidence. That means understanding the child, training the people around that child to understand their needs. And alongside that, positive parenting. Those two things, I can't emphasize enough how important that is for managing this, because it makes a huge difference. And we know this is one of the few things that we know makes a long-term difference. Healthy living is also really important. Weight control, good exercise, not spending 10 hours a day on, a machine. I love gaming. I'm a big gamer, but it can take over these kids' lives, and you've got to be really careful with that. So activity is really important. No, reduced junk food is really important. Staying off fizzy drinks is the other good one as well. And medication is where I come in. And I've put it last because it is last. It is, it's not what we rely on. If I was in America, it might be a bit different. I think they medicate a bit too much. Um, we're quite careful with our medications, but we do have lots of options with medication. But that we can talk about that in the questions. And then the last thing I want to talk about, and this might come out in the questions, is the challenges. Girls versus boys, I think we're better at that now than we used to be, and it's certainly getting more recognized. I think schools are better at it than they used to be, actually, because it's more recognized. So I think that's not too bad. Comorbidities like autism and mood and anxiety, I think again we're better at it than we used to be. It's still a bit of a challenge, and reaching out to CAMS, it's quite hard. CAMS are under the cosh, they're overwhelmed, and I think their ability to outreach and support is more limited than it used to be. In Swindon, certainly it's a real challenge because they don't take on these cases. They're not commissioned to take on these cases. They don't do ADHD necessarily. So that's been a real challenge in terms of understanding what the impact of mood and anxiety is. Um, Sleep, appetite, and emotional regulation. So the big thing about ADHD, it's not just about inattention and hyperactivity. It's also about these kids are often dysregulated with their sleep, with their appetite, with their emotional regulation. So you've got to be really aware of that side of it. Um, uh, the other big thing is adult referrals and transition, and that is enormous for us. We transition probably about 20, maybe a little bit more a year now, 20 to 25 a year, and they are in limbo at the moment, which I'm sure everyone is aware of, but that is a struggle. Medication shortages, those that have children with ADHD will know this, that medication shortages have been a real issue. That has been a problem in the last 2.5 years, 2 years. It hit crisis point last year, where we literally ran out of almost everything. I mean, it was frightening. That's I don't know why. I haven't got an answer from anybody as to why the medication is shortage. I think it's national. Some of it is about suppliers. Some of it is about our local service. Some of it is some national issue. I don't know what it is. Um, and I think the last thing, needs versus labels, and I touched upon this. I mean, if you take one takeaway from this, this is not about labeling kids. This is not about finding a disorder. This is about understanding what do they need to fulfill their potential. In Swindon, I often see these kids and they've got so much potential. I can see the potential shine out, but they're not achieving it because of all sorts of barriers, one of which might be ADHD. But it is often just one barrier. There are loads of other barriers for these kids. And I think if there's one takeaway, I think it's really important for all of you who have kids or connect with kids to remember this is about their needs and what they need to achieve their potential. And hopefully this will help you work towards that. And that's it. I've gone a bit over. I knew it wouldn't be whistle stop, and I'd go a bit over. But we've still got a bit of time for questions. This slide is from a lovely web comic that I do. It's called ADD, but the comic's called XKCD if anyone's familiar. And I really like this version of ADD.